Okay, hello everyone, welcome, bonjour, bienvenue. Thank you so much for joining us this afternoon for our webinar. My name is Blair Elliott and I am the Communications and Events Associate at the McGill Institute for the Study of Canada. I would like to begin by acknowledging today that while we meet on a virtual platform, McGill University is located on land which has long served as a site of meeting and exchange amongst Indigenous people, including the Haudenosaunee and the Anishinaabe nations. We do this to acknowledge the importance of the land upon which we work, study, and live, and to acknowledge the complex web of relationships of which we are all a part. The McGill Institute for the Study of Canada, or MISC, is the Centre for Canadian, Quebec, and Indigenous Studies programs at McGill University. MISC supports a multidisciplinary approach to the study of Canada by bringing together students, researchers, and practitioners to discuss important issues about the country's past, present, and future. In addition to our academic programs, MISC also hosts public events, such as this conversation today, on a wide range of policy-focused topics that are important to Canadians. Before we get into the discussion, I want to let everyone know that today's event is being recorded and it will be shared on our YouTube channel later this week, where you can also watch all of MISC's other past events. If you have any questions at any point during the event for Cynthia, you can submit them using the Q&A function found at the bottom of your screen, and our director, Danielle Baillant, will get to those after her talk. Our event today is co-hosted by our friends at the Center for Research and Expertise in Social Gerontology and McGill's Institute for Health and Social Policy. To get us started today, I would like to introduce Arijit Nandi, Associate Professor, who is cross-appointed to the IHSP and the Department of Epidemiology at McGill University. All right.
Thank you, Blair, and thanks to Professor Baillant and all of our colleagues at MISC for inviting the Institute for Health and Social Policy to co-host this event. For those of you who are new to our institute, it's a multidisciplinary center for research, training, and cross-sectoral collaboration on issues of social policy, health, and well-being. Its activities focus on how policy is formulated and implemented across different contexts and how policy affects population health and well-being. I now have the great pleasure of introducing our speaker today, Dr. Cynthia Cranford. Dr. Cranford is Professor of Sociology at the University of Toronto. She studies inequalities of gender, work, and migration, and collective efforts to resist them. Her work has been published in a range of journals, including Gender and Society, Industrial Relations, Social Problems, Sociological Theory and Work, Employment and Society, and she's a co-author of Self-Employed Workers Organized, published by McGill Queen's University Press. So without further delay, I'm going to hand it over to Dr. Cranford. Thanks again so much for taking the time to be with us today. And as Blair said, for our audience members, as questions certainly will be stimulated by Dr. Cranford's remarks, please be sure to put your questions in the chat. So we look forward to a very vibrant Q&A after the talk today. Thanks.
Okay, thank you very much, Professor Nandi, for that introduction. And thank you to the three research centers for organizing this talk and inviting me to speak today. I'm going to share my screen. And I have a slideshow. Able to see the slideshow. Okay, so I'm going to go ahead and get started. So I'm going to be talking today about my recently published book, Home Care Fault Lines by Cornell University's ILR Press. Home care is a window into the complexity of inequality. It also sheds light on the potential for challenging inequalities. Indeed, several studies argue that coalitions between home care workers on the one hand and elderly or disabled people who receive home care on the other hand are essential to achieving both quality care and quality work. Yet my research also shows that we need to recognize and mediate tensions if alliances are going to be able to tackle structural fault lines reflecting complex inequalities. Change home care to minimize tensions and maximize the potential for alliances. This is the question that I answer in Home Care Fault Lines, and I do so by comparing how 4 government-funded programs differ in the way they organize home care. So I focus on most personal in-home support, that is paid help with daily activities like bathing and eating. So I don't focus on clearly medical care provided by nurses, registered nurses. And so what I'd like to do in this talk is give an overview of my argument in the book, a summary of the methods and data on which it's based. Then I'll give a peek at one of my case studies to just give you a flavor of my analysis, which is a qualitative, small n comparative analysis. And then I'll end with my conclusion that an intimate community unionism can move us towards both quality care and quality work. Okay. So using intersectional gender analysis and scholarship from a range of theoretical and empirical literatures on care labor, on domestic work, from aging and disability studies, I analyze how people who provide and receive home care are marginalized differently, shaping unique experiences and interests. They are located differently within various axes of oppression that form a complex matrix, to use Patricia Hill Collins' concepts. Elderly and disabled people face marginalization vis-a-vis a state and society that values independence. Some people interviewed for this book had been in care institutions before home care that cast them wholly as dependents, while others feared going into them. Still, others had long relied on insufficient family help at home. And in this context, elderly and disabled people desire flexible services to fit their varying needs, and they seek dignity. So when they come to home care, they're seeking these flexible services with dignity. Home care workers experience a different face of oppression, to quote Iris Marion Young, one defined by devaluation and lack of recognition within class and gender inequalities. While the vast majority of workers are women, there are some men who do this work within disability support services. Yet the majority of home care workers are immigrant women in the urban areas of rich countries, and these immigrant women are from poor countries. And in these contexts, racialization through nationality, through legal status, language, accent, religion, culture, and/or skin color infuses their economic insecurity and their claims for security. So workers thus seek both fair employment contracts and respect. So with this framework, I juxtapose the experiences of elderly and disabled people on the one hand and workers on the other, and I show how a tension between flexibility and security potentially exists across various home care programs. Yet, my comparative analysis of 4 programs tries to excavate the dynamics that exacerbate or alleviate tensions. Okay, so what I want to do next is give you kind of an overview of my argument, my more empirical argument in relation to the care work scholarship. So I join other care work scholars who find that government funding based on a narrow medical definition of need and the delivery of care through a market logic encourages employers to hire workers on precarious contracts. Narrow funding and market logic in turn reinforce gendered and racialized labor market inequalities. This represents continuity with long-standing racialized and gendered divisions of care labor, as Evelyn Nakano-Glenn has argued. So racialized and gendered precarious employment also threatens the quality of services for elderly and disabled people. So building on this care work scholarship, my analysis reveals how narrow funding dovetails with marketization to either erase traditional employers altogether or to discourage the employers who are present, the various types of employers, from mediating tensions in the labor process. We say in sociology of work, the labor process, the tensions between workers and service users or receivers and any level of management that may or may not be present. These are tensions about what is done, what does the job entail, when it's done, how it's done. Narrow funding coupled with marketization also makes collective action difficult thus requiring innovative alliances between labor and other social movements that represent the clients or service receivers or service users. Yet I also show how a broader social funding model coupled with nonprofit delivery encourages more employer intervention to mediate tensions in the labor process. This is in part because these nonprofit environments also are more likely to have collective representation for both workers in the form of unions or perhaps other worker centers, and also for the clients or service users or receivers. Okay, so what I'd like to do now is just tell you a little bit about the data and the case studies that these arguments are based on. So my analysis in home care fault lines rests on over 300 interviews, revealing how a variety of players shape the conditions of home care in unique contexts. Over several years, comprising, as I said, 4 case studies, research teams interviewed personal support workers who were the frontline workers paid to assist with daily activities, and elderly and disabled adults who receive or need this assistance. We also interviewed caseworkers who assign hours of service, any employers, senior disability and labor activists and advocates, and we collected data from the public documents of the program. This research was supported over the years by 2 SSHRC grants, which funded the travel, honoraria, community partnerships, and research assistance that made these studies possible. So these are unique contexts, and 3 of my case studies are in Toronto. So they're sort of nested in the policy context of Ontario in Canada. And then 1 of my case studies is in Los Angeles, nested in the policy context of California in the larger context of the US. And together they cover elder care and disability support. My interviews focused on the urban labor markets of the Greater Toronto area and the Los Angeles County. But as I said, the policy analysis is nested in the provincial and in the end, sometimes federal context. So let me tell you a little bit about the 4 programs. So first, I have the direct funding program in Toronto. It's called Direct Funding Self-Managed Attendant Services. And this is an example of what in the literature is sometimes called individualized funding, or sometimes called direct funding, direct payments in the UK. And in Toronto, the program is quite unique. It serves people with physical disabilities who are able to be self-managers to manage their own services and hire and fire their own aides. Funding here is shaped by a social model, the social independent living model of disability, which emphasizes non-medical assistance with a wide variety of daily activities. So things that might be considered medical care in the home care, home health model here is seen as a routine activity of daily living. The workers are employees of individual self-managers, to use the program terminology, and they are called, often called PAs or personal attendants. The funding is universal in that it's not means tested, although, as I'm sure you know, the Federal Canada Health Act does not guarantee personal support at home, but leaves it up to provincial discretion. And so you have variation across provinces. Okay, so next, I want to just tell you a little bit about the in-home supportive services program in Los Angeles, which I characterize as sort of a hybrid between an individualized model and also a state. It has some more state provision than indirect funding. So here we also have the IHSS is also shaped by the social independent living model. But in Los Angeles, the majority of people receiving it are actually elderly people. But the design of it was very much drew on this independent living movement and model. This is a means-tested program in the context of the United States, and it's funded by Medicaid. So you have to be poor to receive this program. The independent living model in IHSS combines with a family model in that people can pay even their close family members to be their providers, and usually it's parents and children. this is not permitted in my other case studies, although there are other situations in Canada where direct funding in different provinces, for example, allow hiring family members, but not close family members like your children. Okay, so attendance services in Toronto is one of two of my contract agency cases where there's an agency that mediates the relationship. It's not a direct hiring situation. So in IHSS, you have, let me just step back a minute. For IHSS, the consumers hire the workers directly, but it's this state hybrid because the state actually pays the worker. Whereas in direct funding, the money goes directly to the self-manager to hire their aide. So this is why there's more state involvement. So the state actually pays the worker and therefore takes out, you know, employment insurance and Social Security and things like that. Okay, so, but there's no agency that mediates that relationship. In my other two models, there is an agency, and I have a for-profit and a nonprofit contrast there that I make. So attendance services in Toronto provides assistance to people who direct workers to help them with routine daily activities. It's also within this social independent living model, initially designed for younger people with disabilities, although people are aging in place. But you know, it's mediated by an agency here. So the agency is the employer, not the individual. Here, all of the agencies in attendance services are nonprofit. Sometimes the service users are called consumers, reflecting that independent living movement, but sometimes they're called clients, reflecting the kind of formalization of this independent living philosophy and agency-based social services. Okay, finally, the home care program in Toronto, so is often called home health, provides long-term care to elderly and chronically ill people, as well as home health care to those recovering from acute illnesses. Now, my study doesn't focus on the acute aspects of the workers, and the clients that I interviewed were, you know, frail elderly people or people with chronic disabilities, and the workers were not providing acute care. But I want to emphasize that this long-term care is housed within this kind of medical model as opposed to a social independent living model. So this prioritizes acute over long-term care needs. Here, people are called clients by the program usually, and personal support workers or PSWs. So here, like in the other Toronto programs, we have, you know, provincially universal care, but we have means testing of housework. So housework used to be covered by this program, and now it's means tested. So it's the personal care that is provincially universal. Here, the other contrast is most of the agencies are now for-profit, sorry. So we have this for-profit, nonprofit contrast in the attendance services and the home care cases. So when I speak of home care generally, as in this talk, as in the title of the book, I am including all these cases of state-funded assistance with daily non-medical activities provided to elderly or disabled people in their homes. I'm not just talking about home health. Okay, so what I would like to do now is just give you a flavor of one of my case studies, and so you can get a sense of the kind of people that I interviewed and the kind of tensions between flexibility and security that I analyze in this case, and that I compare to the other contexts. So home care illustrates the classic trade-off noted in the work and labor literature between flexibility for employers and insecurity for workers. Flexibility also accrues to the government in this context of state-funded services, but not the home care clients. So this is the overall argument of the chapter. I'm going to give you a little bit of context of the case, and then I'm going to talk a bit more about flexibility and security. So the Ontario Ministry of Health funds home care, but it distanced itself from responsibilities to workers by contracting services to agencies. As in other contract agency models, the legal employer is the agency that hires the workers and sends them to clients' homes. In the mid-90s, Ontario restructured its home care program in a context of cuts from the federal government transport payments, and it introduced what is called managed competition, allowing for-profit companies to compete with longstanding nonprofits for service provision contracts. The government justified this move to managed competition by claiming it would provide consumer choice and efficiencies as well. But the effort to contain healthcare costs in Ontario as elsewhere by closing some hospitals, transferring more medical care to home care drove this restructuring as well. In the late 90s, the government rationed the in-home long-term portion by giving priority to acute patients and making housework means tested, as I mentioned. So in this context, one agency manager that I interviewed said the average client is getting 2 hours of services in a week, which is very, very limited. And a huge number of clients actually only get 1 hour of service. And in reference to her single bath a week, Alice, a client, bitterly said, it's disgusting. So many of the people that we interviewed had experienced a cutback in services, especially for housework, but also in basic kind of body care. Family could not fill in all the personal support and housework gaps since women who do the majority of unpaid care work were employed or looking after children or both. So in the late 2000s, the government put this managed competition on hold. And in 2013, it abandoned the competition part, the very competitive part, which determined very short-term contracts. But it still has a contract model, and the for-profits are still the majority. Workers and clients' lives, therefore, continue to be shaped by this system. And one of the key ways that I want to emphasize that their lives continue to be shaped by the system is the limited, the effect of managed competition on collective representation of both the clients and the workers. So with this restructuring, the government disbanded the voluntary board of directors and replaced it with government appointed executive directors and boards of directors that reduced input from clients. Contracting out also made it difficult to unionize because labor legislation in Ontario, as in some other places, is based on the post-World War II factory model. This assumes a kind of what's called in the literature a standard employment relationship, or a direct and continuous relationship between a single employer and a worker, and work that takes place in a formal workplace, which is at odds with this competitive contract model and even other contract models in home-based work. So several of the nonprofit agencies that lost contracts in this managed competition process to deliver services were unionized, and most of the nonprofits that gained them were not unionized, although a few large for-profits have since been unionized, and unions are organizing right now, continue to organize in this sector. So nevertheless, there's a lack of significant union presence in this sector, especially in comparison to my nonprofit case. Coupled with next to no collective representation for the clients. And this shapes the flexibility security tension. So at the labor market level, the flexibility mostly accrued to the agencies, not the clients, as I said. By labor market, I mean, the literature often talks about flexibility for employers, sometimes for the government. I also am talking about labor market flexibility for clients. And what I mean by this is the ability to decide and change who provides your services, these personal services. So a part of this is a question about kind of flexibility for whom, right? So home care clients did not hire their own workers, as I said, and the agencies also did not accommodate clients' personal preferences usually in the initial assignment of workers. However, in non-unionized agencies, which are now the majority, clients were sometimes able to switch workers based on highly subjective criteria. Nevertheless, my analysis showed that the degree of clients' flexibility not only relies on the type of agency, whether it's non-union and for-profit, but also on the social location of the client. So men or women who were young, who were white, who were born in Canada, who had class privilege, were most commonly the ones who would ask for a switch in a worker, and the for-profit non-unionized companies were more likely to accommodate the request. So for example, one man that I interviewed who I called Gerald, these are all pseudonyms, I should say, a white man born in Canada in his early 60s, told the manager in the home care agency, for-profit non-unionized home care agency, about previous issues with workers. And he said about the new one, I hope he's got a personality. He's conveying the conversation that he had with the scheduler, the coordinator, the manager in the agency. In response, the scheduling coordinator told him that if he was not happy with the worker, to call them. In contrast, Agatha, an elderly Jewish immigrant woman, said that the for-profit non-union agency had never asked her about the workers, and she had never complained about the workers. And she added, money talks and I've got no money. So even though she wasn't paying for the service, her sense was that I don't have this sort of right to complain. In short, even these for-profit non-unionized companies didn't offer flexibility to most clients, only those who complained the loudest. Within a context of rationed state funding, the agencies tried to preserve their own flexibility and meet the needs of, or the requests, sometimes the needs or the requests of select clients who were empowered enough to assert their desire for flexibility. And they did so by defining workers as casual. So for-profit non-unionized agencies were the most extreme in this strategy. The for-profit manager that I interviewed, except one who refused to answer the question, said that the vast majority of their workers were casual without a set number of hours. They argued that classifying workers as casual was necessary to provide scheduling flexibility for clients, although, as I mentioned, flexibility only accrued to some clients. Employers also claimed that casual classification provided choice to workers to take a client or to decline a client when you're called or to take it. But interviews with workers, of course, illuminated the negative implications of this choice, and also illuminated the reality that many workers, particularly immigrant women, have little choice but to accept the work they're offered. When we asked workers whether they were assigned another client if they lost one, they explained that this was far from guaranteed. Comments like maybe, they try, it depends, and others conveying contingency were common among workers' descriptions of the implications of losing a client, whether you lost the client because they went to long-term care or you lost the client because they called and didn't want you to come back. Wenna summed up this precarity well when she said that waiting to get a client with equivalent hours could be a day, could be a year. Employment insecurity combined with insecurity in wages and benefits, which in turn exacerbated these contingent connections between workers and clients because the turnover rates are so high. Notably, and workers have multiple jobs, they sign up with multiple agencies. Notably, home care PSWs earn much less than PSWs in nursing homes and hospitals. Those classified as casual are not fully covered by the basic floor established by the Ontario Employment Standards Act. So they didn't receive things like paid holidays, severance pay, nor do these workers have sick pay. Okay, so in each of my case studies, I examined this tension between flexibility and security at the labor market level and the labor process level. So tensions in the labor process, as I briefly mentioned, concern tensions over sort of what is provided, when it's provided, and how it's provided. And I want to just illustrate one tension that I identified in my broader comparative analysis. And this one I call the tension between time and task. So this is the tension between people's needs for help with the range of changing activities in various times versus a defined job description at a stable time, often desired by workers. Okay. Just realizing that I've been talking quite a while without just checking in that there's nothing in this chat about me breaking up or anything, and I've had said that in the past. So I just checked that. Okay, so this time versus task tension. I'm going to give you an example of this. Okay, so the government's rationed funding influenced the way the managers formally and informally approach this time versus task tension and other tensions that I analyze in the book. And this, of course, shaped how the PSWs and the clients tried to negotiate flexibility and security. So the managers that I interviewed described objective rules regarding what was done, what was supposed to be done in the home workplaces. For example, one manager explained that in the contract with the government, they were only allowed to provide certain services like personal care, such as bathing, assistance with mobility, and summed it up and said, we're not there as a housemaking service, for example. PSWs could provide what's often called light housekeeping, but the government defined this as the worker cleaning up the immediate area affected by the personal care tasks. So for example, mopping the bathroom floor, mopping the water up on the bathroom floor after giving a bath so the client wouldn't slip when they stepped out, but not cleaning the whole bathroom. Managers spoke of the care plan as an objective guide to what was to be done, but they did not enforce the care plan or support workers to negotiate tensions around it. For example, referring to the workers, one manager said, sometimes they don't feel comfortable advocating for themselves or to say no. I mean, there's a lot of that, and it's so hard because it's community-based. We try to monitor them, but how can we really monitor? Other managers likewise explained away their lack of intervention to the self-sacrificial, usually woman worker, and the difficulty of monitoring the home-based services. So rather than proactively supporting workers or clients, they addressed problems ad hoc, or more commonly, they left it up to workers and clients to negotiate one-on-one. And if there was a problem, they simply switched the workers. In contrast to this official definition of the services as a set of discrete tasks, home care clients wanted and needed flexible support to fit with their changing needs. For example, Eleanor, who was in her 70s and had osteoarthritis and had experienced multiple bone fractures, said that the home care worker helped her mostly around the house because she wanted to, quote, persevere and take a bit longer to do her own bath and to do her own cooking. This was important to her sense of independence. So the worker changed the sheets on her bed and did the other laundry, cleaned her bathroom, and if she had any time left over, she might dust or something, Eleanor said. Justifying this allocating of tasks based on need, Eleanor said, I consider what she's doing for me to be personal care. A few clients admitted that workers stayed over paid time to help with the housework and other tasks that had now been defined out of the job. For example, Claire, a 51-year-old woman who had incontinence, mental health issues, and difficulties walking, said this of her worker: she will stay an extra half hour, 45 minutes, and she doesn't get paid for it. But the difficulty I have in trying to get my laundry, I mean, there's just no way I can vacuum. Claire, like most clients that we interviewed, was grateful for the worker's unpaid help rather than expecting it or asking directly for it. Nearly all the workers spoke of providing some services as a favor or of giving a little extra to some clients some of the time, and this is also reflected in the literature. The vast majority of workers gave examples of staying over their scheduled time, and 2/3 explicitly mentioned instances of doing so unpaid at one point or another. Yet, in this context of state-sanctioned and agency-condoned economy of favors, workers did extra for some clients, but not others. Nearly 3/4 of the workers that we interviewed reported both giving favors and resisting doing so. For some clients or not others, or changing over time. For example, when she first started the job, Tala stayed over her scheduled paid time in order to, quote, pacify upset clients, because she said, you can't just leave them. And since compassion sometimes has a tricky way, she said. But by the time, so she's retrospectively explaining this to us, but by the time we interviewed her, Tala was adamant that workers should tell their supervisors if the client consistently did not want body care, but asked instead for housework. Because otherwise, if you did that, if you did the housework for one, she's gonna ask you to do that again. And perhaps ask the next worker who came the next day. So a gendered economy of favors was under strain here, I argue in the chapter, not only due to rationed funding, but also to racialization in the labor market. Some workers of color recounted overt rejection from white clients or racial slurs, and many more experienced being treated like a maid. For example, Tanis told us, quote, "Some people never have a Black person who would come into their home. And some asked her to clean because they did not want her to, quote, touch them personally, or they might flinch when I go to touch them. They might pull away," Tanis explained. Yet she insisted on respect in our interview, stating, "We're only human." So the expectation of cleaning when it was no longer part of the job was clearly a racialized experience. Another question that I ask in all of my chapters is whether collective support on both sides can help to alleviate some of these tensions at the labor process or labor market level. So I want to turn to just focus on collective support on the worker side through unions, and think a little bit about unions and alliances with client groups. Okay. So if unions are going to improve workers' conditions in contract employment, they must reject a narrow business unionism focused only on workers' issues at the prototypical factory in favor of what's called a social unionism that links economic and social justice issues in the political realm, right? This is often achieved through alliances between labor and social movements that are representing the clients or service users, especially in the public sector or in publicly funded work. So as I said, contracting out reduced the number of unionized workers and limited the power of unions, but several unions are organizing in this sector. The Service Employees International Union represents most of the unionized workers in Ontario. This union tried to augment workers' labor market security by targeting both the state as funder and the agency employers to improve compensation, hourly wages, pay for travel time, more benefits. They also tried to tackle employment security by pushing the state to reform the most competitive features of the service delivery model. And the critique of this union and other unions and academics and some nonprofit employers was key to the halting of the very short-term contracts in this model. The union members that we interviewed, we interviewed union and non-union workers, and the ones who were unionized spoke positively of their union for its role in halting the managed competition system that so often put people out of work. The union framed its own effort to improve conditions in the labor market in terms of wages and employment security as connecting quality care to quality work. So if we have better wages, we will reduce turnover and that will be better for clients. But actual concrete alliances or coalitions with specific client groups have been either very broad, like the Ontario Health Coalition, focusing on various critiques of privatization across the healthcare sector, or very short-lived or very recent. And furthermore, at the labor process level, so at these two levels, a business unionism prevailed. So business unionism is this kind of legalistic, bureaucratic, staff-driven servicing of workplace problems. And this was evident. So union officials recognized that some of the tensions in the labor process didn't stem so clearly from inadequate funding or the contract agency model and its competitive features. Tensions like sexual harassment, verbal abuse, racialization, whether explicit or more subtle. So they recognized this, but they didn't have a clear strategy to address these tensions, I call tensions in the labor process. Union officials described this legalistic procedure of collective bargaining and the contract provisions that was hard to maneuver given the individual home workplaces where workers don't know each other. They don't know their steward or worker representative in the union. So in the chapter, I show how the lack of union strategy to address tensions with clients in the home workplaces weakened and can weaken workers' support for the union. So even unions who said positive things about their union for, getting travel pay were critical, felt like, the union didn't quite understand the tensions in the workplace, in the home workplaces. So in the conclusion of the book, in fact, none of my cases achieve flexibility with security at both of these levels of analysis. So in the conclusion of the book, I talk about what I call intimate community unionism by comparing my case studies, but also other cases in the literature to think about what unions, but also other workers' organizations in alliances with client groups can do if the goal is flexibility with security or quality care and quality work. So I'm just going to say a little bit about this intimate community unionism and sum things up here. Home care brings together the worlds of labor and social service, complexly interlocking inequalities of race, class, and gender with those of age and disability that are experienced differently by workers and people in need. So in the conclusion, as I said, I chart the potential for flexibility with security through comparative analysis. In order to reflect the unique realities of this work, I argue we need an intimate community unionism. Intimate community unionism at its heart or at its center would entail democratic alliances or coalitions between labor and groups of elderly and disabled people to address tensions in the labor process and more structural fault lines at the labor market and state levels. So I'll say a little bit about these three kind of prongs. First, coalitions need to push for universal social funding model. Many have talked about this, much more conversation about this, thankfully, in the context of COVID. And I also draw attention in the book to the lessons that I learned by comparing the medical model that I talked to you about today with the social models, independent living model, where I found that the tensions were most extreme in the medical model, these tensions I talked to you about today, given its narrow definition of care that excludes many activities of daily living needed by disabled and elderly people. So in addition to the need for universal funding of home care that's guaranteed in the federal Canada Health Act, we also need an expanded vision of what should be funded. Funding should cover a broad array of daily physical activities, emotional support, and housework. The second kind of prong of this intimate community unionism is at the labor market level, where I argue that we need labor market intermediaries that are culturally sensitive and state funded. So in the book, I compare nonprofit and for-profit agency models, and this illuminates the problems with for-profit companies that act like little more than temp agencies and show that nonprofits are better at balancing flexibility and security. However, in my two other cases of direct hire, the direct funding and the IHSS in Los Angeles too, there are no agencies and the client's needs are intermittent, right? They might need someone in the morning for a couple hours and the evening for a couple hours. So we need new forms of nonprofit labor market intermediaries that connect workers to multiple jobs and link people in need to multiple workers. Effective labor market intermediaries need to have input also from collectivities of home care receivers and workers if they are to meet the needs of diverse groups of people, ranging from younger people with disability to elderly immigrant clients. Labor market intermediaries also need to include democratic structures that limit the discriminatory possibility of personalism in hiring. Such intermediaries would not need to replace paid care by family or friends, which is extensive in the two direct hiring cases, but it could support it, allowing family and friends to have real choice in providing care and also to supplement the meager hours and earnings for one person with that from several others in a way that is fair and mediated. Academics have noted the need for nonprofit intermediaries, and some organizations that I profile in the conclusion of home care receivers, independent living centers, for example, have them. but rarely are they adequately resourced. And this is why I argue they need to be state funded. Labor market intermediaries are key to ensuring that workers do not stay in jobs providing such intimate support only for economic survival. And so they have other options to get other jobs. And they are key to ensuring that people in need do not keep problematic workers out of desperation because they can't find anything else. However, at the same time, if we are to ensure that tensions are not simply displaced to the labor market through through firing and quitting, we need this third piece, right? In-home personal support includes tensions, some of which stem from the funding model and the organization of the labor market, but others that are not necessarily resolved just through better and broader funding, or through labor market security, through these new kinds of intermediaries that allow for security with flexibility. We also need to recognize tensions that stem from different locations of workers and service users or receivers within a matrix of inequalities. We need to recognize this and think about anti-racist education, anti-ableist education, other forms of mediating and educating and challenging these inequalities. My comparative analysis suggests we need deeply democratic alliances between organizations and movements representing workers and service users or receivers to provide support in negotiating these complex tensions at the intimate level of the labor process. And given the bureaucratic tendency of even the most innovative and progressive unions, in the conclusion, I also point to community-based labor organizing for inspiration. These organizations, especially the feminist ones, are using things like popular education, leadership development of women workers, often immigrant women workers, and other such methods to grapple with and try to challenge the intersecting inequalities in care work and domestic work. Overall, my comparative analysis shows how democratic alliances between home care users or receivers and workers and their organizations, their movements, their allies are really what is key to creating the kind of social awareness and political will necessary to make these kinds of multi-level systemic changes if the goal is really flexible quality care and secure quality work. Okay, so I will stop there. Thank you so much.